But much more of that discussion. Allow me jet straight to our guests this evening. And without wasting any more time, I have two distinguished gentlemen from the medical profession. One of them is Dr. Mutumba Robert, who is the Principal Medical Officer, Reproductive and Child Health Department at the Ministry of Health. Dr. Mutumba, a pleasure having you. Good evening and say hello to our viewers.
Yes, so good evening, viewers, and thank you, Mildred. First of all, it's a great opportunity for us to come in here and have this wonderful conversation regarding the health of mothers, newborns, and children in Uganda. Thank you.
Thank you so much, Dr. Robert, for sparing off time. We'll be taking you into tomorrow, which is a Tuesday, and the discussion will be going on up to midnight. I also have Dr. J.P. Bagala, who is an obs and gyn specialist, and that's obstetrics and gynecology. He is the executive director of Women's Health and Research Institute. So we'll be talking lots of statistics and the realities of these statistics. Dr. Bagala, thank you so much for joining us. Say hello to our viewers.
Most welcome indeed, Mildred. I'm very honored to be here, and I'm really looking forward to the discussion for the mothers and the newborn, considering that that's my area of specialization and in close working relationship with the Ministry of Health.
Exactly.
Thanks very much indeed for hosting us.
A pleasure, Dr. Bagala, and we can't wait to listen to a lot of that information coming through. First of all, I'll start off with you, Dr. Robert Mutumba. When we talk about maternal and child health services, for lack of a better word or for a broader perspective, what exactly are we looking at in this context?
Yeah, so basically looking at maternal newborn, some people tend to forget the newborn.
Oh, yes.
And I tend to be a champion for the newborn. So it's the comprehensive package of healthcare services that largely the pregnant women receive. And that's actually right before pregnancy, but also the care that they receive at the time when they are pregnant, during labor and childbirth, but also the what we term as the postnatal or the postpartum period, the period after they've given birth. So that comprehensive package of healthcare services that this mother receives is largely what we refer to as the maternal healthcare service, but also immediately after delivery, and also before the baby is actually delivered. There is also a wide range of services that this newborn receives right from the time the baby is not yet born to the period shortly after birth, but also the weeks that follow after birth through the up to actually 5 years of age is what we largely term as the newborn, the neonatal, but also the child health range of services.
You're talking about the care right before pregnancy. When we're talking maternal, thinking maternal for most people, they're only thinking at that time when you realize, oops, I'm pregnant. Whether it is expected or unexpected, and that's the only time that they get to think about now matters maternal services. The pre, if you may, the pre, what is involved in there? What is that many people haven't paid attention to, that the Ministry of Health is ready to offer as well, but we only think about it after realizing that you actually missed your periods?
Yeah, so thank you. The care that a mother deserves or receives before conception actually, first of all, involves ensuring that they only conceive only and when they must conceive. And again, you'll be hearing people speaking to family planning. And that ensures that a mother or a woman should only conceive, should only become pregnant only and only when they are prepared to actually take care of that pregnancy. We, of course, know that some of the mothers end up having these pregnancies as some sorts of accidents. But ideally, they should be able to prepare both physically, but also emotionally and psychologically before they can actually get pregnant. Of course, that involves a lot in terms of nutrition. It's very common sometimes to have mothers or women conceive when actually they have lots, when the body is actually not well prepared to carry the pregnancy. Ideally, there are certain conditions that will show up, that may show up in a newborn.
Okay.
If the mother, for example, doesn't have good nutrition. There are nutrition deficiencies like folic acid that will eventually lead to congenital abnormalities in a baby. So the preconception care really ensures that the mother is both physically but also psychologically prepared to have this pregnancy to term.
All right, thank you very much. To Dr. Bagala, this is your area of specialization. What are the realities on ground? I love when Dr. Robert speaks about a mother being ready as and when to have a child, but what are the realities on ground?
Thank you very much, Mildred. Yes, of course, we have different categories of mothers, per se.
Okay.
And there is a term we refer to as safe motherhood.
Okay.
You might be familiar with that term. And of course, it has different components that make up safe motherhood. And it also has a very interesting foundation. And one of the components we look at in that foundation is equity for healthcare, but also girl-child education.
Okay.
So why I'm trying to drive to that is that we have
The COVID-19 pandemic, beyond the disease, has presented unprecedented challenges in delivering of services to Ugandans from all walks of life. With the seeds of success in every nation on earth, known to be best planted in women and children, Spotlight UG this Monday, 11th of October 2021, focuses on the delivery of maternal and child health services during the COVID-19 era. On the panel, Dr. Richard Mugahi, the Assistant Commissioner, Health Services for Reproductive and Infant Health at the Ministry of Health, Margaret Mohanga Mugisa, the Minister of State for Health in charge of primary health care, as hosted by Mildred Tuhaise. Send in your questions today via #SpotlightUG. The COVID-19 pandemic, beyond the disease, has presented unprecedented challenges in delivering of services to Ugandans from all walks of life. With the seeds of success in every nation on earth, known to be best planted in women and children, Spotlight UG this Monday, 11th of October 2021, focuses on the delivery of maternal and child health services during the COVID-19 era. On the panel, Dr. Richard Mugahi, the Assistant Commissioner, Health Services for Reproductive and Infant Health at the Ministry of Health, Margaret Mohanga Mugisa, the Minister of State for Health in charge of primary health care, as hosted by Mildred Tuhaise. Send in your questions today via #SpotlightUG. The COVID-19 pandemic, beyond the disease, has presented unprecedented
for male involvement in issues of maternal health, because for families that have had incredible support from the men, the outcomes are more significant from those that have not. So birth preparedness is getting up a bit in the elite societies, compared to the societies that are really not so much well educated, or whose social determinants of health are still very, very low.
Okay, that's an interesting divide, but how we can be able to bridge the gap is the most critical discussion that we should be having. Back to you, Dr. Robert. What has been the situation handling maternal and child health services or issues, including newborns? You said you are an advocate of those. During the COVID-19 era, you've had lockdowns, you've had a lot of attention to COVID-19, treatment because of, even for the private healthcare facilities, probably because of also the finances that were involved. What has been the situation like, and where are we currently?
Yeah, so Mildred and to all our viewers, you're all aware that especially with the declaration of the pandemic in March 2020, there was really some serious disruption in terms of provision of MNCH services. But of course, this was due to the movement restrictions. If you remember clearly the journey that we walked, the presidential directive that was quite tough in terms of movement restrictions, we saw that causing some serious challenges in terms of access to essential MNCH services. But of course, that was more marked in the lockdown of March and April. And we saw actually a significant, drastic reduction in the proportion of pregnant women who were attending ANC, antenatal care, through the months of March, April. But with the lifting, of course, teams sat and realized that the movement restrictions, especially to the pregnant and breastfeeding women, was causing quite a lot of harm. So the president, through, of course, with guidance of the ministry and other entities, lifted the restrictions. And so we saw more women being able to access health care facilities to receive, that wide range of antenatal care services, labor and delivery, but also postnatal services. So the system recovered through May and onwards. So we then had a significant increase in the uptake of antenatal care services. But the disruption in ANC uptake and facility deliveries, the data shows that it was much more marked among the young mothers, the 10 to 19 plus what we categorize as 20 to 24. So we saw that actually hitting that age group like worst. Okay. When it comes to delivery services, during that time, it was also low largely because of access. Despite the fact that health facilities were open, and there were mechanisms to ensure that health workers could get transported to the health facilities to provide the wide range of quality maternal, newborn, and child health services. But of course, with the lifting of the movement restrictions, we saw the recovery. And when you also look at the uptake of family planning services, access to contraceptive services, it was also disrupted through the months of March and April 2020. But later on, with the lifting, of course, we really had now a significant increase in the uptake, and it's kept increasing over time. And I think where we are, we seem to have recovered from that kind of stress that we had on the system. But of course, the rest of the other services, the ministry came up with guidelines on continuity of provision of essential healthcare services. Okay. And I must highlight that maternal, newborn, and child healthcare services constitute actually a top priority on the top on the priority list of the essential healthcare services. And so health workers have been oriented on these guidelines, which were developed through that continuity of essential healthcare services pillar. And so they've really been asked through dissemination of these guidelines to continue providing these RMNCH services and consider them as priority services. And we have actually seen a very significant reduction, including in mortality. And when you look at the annual report on why mothers and babies die in the country, you see that over time, we have actually registered a reduction in the mortality rate over time.
All right. And I come back to Dr. Bagala. You were doing a juxtaposition of the elite, for lack of a better word, elite mother vis-a-vis that mother who will come to the health center during the lockdown and with the restriction of movement and with COVID-19, because there is still a phobia of COVID-19. Many believe, oh, if I go to the hospital, I will be able to contract COVID-19 there. What realities did you see on ground? Dr. Mutumba is talking about, access issues, reduction during that period of time in mothers who are delivering at health facilities. What does this mean for a mother?
So definitely, as Robert mentioned, the extent to which the permission was given, definitely we saw that majority of the mothers around town here were given quite incredible access to their continuity of essential care. And also, we noticed that, I think from the presidential address, you saw that those powers were given to the RDCs to permit these mothers to be able to access care. But of course, when a mother is to get into a facility, and of course, there is that particular delay which significantly contributes to the loss of the mother and the newborn, which we have looked at mostly 3 delays. One is the delay for a mother to say that I should go and seek care. That's the first delay. The second delay is the mother now reaching the facility where this care is going to be provided. And then the third one is when the mother is at the facility, the time within which care is provided. So if you look at our mothers who have the ability in terms of they are economically empowered, the delays are quite low when it comes to the first and the second one. Because if you have a car, I mean, you might be having a sticker, and you can quickly rush to a facility in case you see yourself bleeding and you're pregnant, or you might have seen a danger sign. If you go back to another mother who doesn't have these opportunities around them, that they would need, for instance, to take a border, or they would need to take a taxi, and the health facility may not be within their close proximity, the time that it takes for that mother to reach the facility would be very, very different.
Sure.
So those delays were quite very, very significant. But still, I think within the government's powers, there was that permission that let antenatal care services continue, which are very important when it comes to a pregnant mother. The preconception counseling, if a mother is not yet conceived, that yes, they have decided to conceive, but even, oh, I've missed my periods, I'm pregnant, I need to start antenatal. So there was room, and at all levels of care, from health center 3s to the highest level of facilities, those services were provided. But now they're reaching to these facilities. Those are the delays that we are really contributing to the mortalities that we saw for both the mothers and the newborns. And of course, it varied, definitely. And that's why, as we talk about healthcare, the social determinants of health, where you have aspects of education and other economic empowering aspects for a mother, are very, very important.
Let's delve into these 3 delays, because for someone out there, it may not be something they've paid attention to. How significant, in terms of whether positive or negative, are these 3 delays, and how should one pay attention to them? How have they impacted the statistics that we're talking about of maternal and child health services?
So the 3 delays are very significant to maternal and newborn health. And of course, the first delay to start with, the delay to seek care. So, and this comes from the perspective that, does the mother know the circumstances that surround a pregnancy, which is always challenging for first-time mothers, because sometimes they are not really aware of some signs that I should really be conscious of my baby's movement. If my baby has stopped moving within 24 hours, I should seek care immediately. That if I have a fever, I need to seek care. That if I start bleeding at whatsoever stage of my pregnancy, I should seek care.
Some of the mothers at .com, we ask Google, we consult, and we are fine with what we've gotten there.
Yes, and that's where the difference comes in, because it's quite easy for someone to seek care if they are alone or they are one individual. But we always take a pregnant mother to be two people in one.
Oh, yes.
And so the way we approach a pregnant mother is different from the way we would approach an individual. And even in our management, we consider for any medication we are going to give, what is the effect of this medicine to the mother, but what's also the effect of this medicine to the baby.
Oh, yeah.
And that's why if you have a malaria or a fever or something of the sort, before you are beyond 12 weeks, there are medicines that we shall not give you, because we are considering you and the baby that you're carrying.
Oh, yeah.
So that delay, those danger signs, we call them the danger signs within pregnancy, become very important. And if the mother is not well oriented about these danger signs, they may come to the facility when it's very late, when we can't salvage anything. And of course, as Dr. Robert will mention, we have these leading causes of death amongst the mothers, and one of them is bleeding.
Bleeding.
Yes, bleeding, and contributes a very significant percentage.
Close to half of all the mothers would die.
So you can imagine.
Bleeding.
And that's during pregnancy. So either you bleed while the baby is still in your womb, or you bleed after giving birth. Then the other one is pressures in pregnancy. Pressures in pregnancy.
Okay.
And all these present in a very tricky way. Mostly pressure in pregnancy. For the bleeding, you can see that, oh, I'm having a bleed. And then you'll be very cautious and rush. But the pressure in pregnancy has its tricky signs. That,
Is that what leads many women into preeclampsia? Or that's the
exactly.
situation?
I didn't want to use that
We can
term.
go a little bit medical here. Okay.
I didn't want to use that term. But of course, so there are particular things that we look at. That if a mother has reached midway their pregnancy, and that we are looking at 20 weeks and above, and they're getting that constant headache, they are getting that terrible chest pain that has not been there before, and they're getting that very bad abdominal pain that has not been there before. They are getting very terrible sight, or their sight is becoming blurry. Those are danger signs. But for a first-time mother who has not been attending antenatal care, which is very, very important, you can't know. So by the time you say that I'm going to seek care, or by the time you are carried to the facility, you're already convulsing. And a convulsion for a mother who has, as you said, preeclampsia, which is our medical term, but with pressure in pregnancy, that means that that's the critical stage of pressure in pregnancy. And that claims the biggest percentage of mothers who come in that kind of state. So it becomes very important for mothers to seek care. But as I mentioned, this is where supporting these mothers, the men must come in and support, because sometimes these mothers don't have some transport money, isn't it? For the Kampala ladies, they may have. But elsewhere, I want to go and see a doctor. The men should be able to support their wives in that process. Then secondly, the second delay is reaching the facility. And that's where we get in the ambulances and the other means of transport that will take these mothers to the facilities.
And I'll just hold you right there. The means of transport. We're looking at this rural lady who is going to either use a bicycle or a border. Do we have particular means of transport that would be dangerous for a pregnant mother?
Yes, of course, our worry mostly is if this mother gets any, and depending on the stage of the pregnancy, if the pregnancy is really advanced, we are a bit cautious for this mother not to progress into unprepared labor. So labor kickstarts without reaching time. But our biggest worry is if any aspect of injury happens to this pregnant mother. And there we are looking at the baby who is inside. So if we have majority of means of transport, the borders, the taxis, the ambulances have been safe, and our roads have improved as well, isn't it? Yes. so that mother can be moved quite swiftly to the facility. So the means by which, and Dr. Robert will mention about the ambulance services, Ministry of Health has done incredible work. around extending ambulance services to all regions of this country, which is very, very important in addressing the second delay. Delay is to us as the health workers, as who are on this show. We really have to work very, very hard. And it's what you say, the institutional mortalities are because of that third delay, mostly. Because when a mother comes in,
and there is no doctor, there is no midwife,
whether they have been referred or they are just walk-in clients, and they are pregnant, we have to act swiftly. We have to act quickly until we have thoroughly investigated and ruled out any other danger signs. We must act quickly and address the concerns that this mother has come with. So we are looking at midwives, doctors, interns, and obstetricians and gynecologists. Very, very important to ensure that these mothers don't delay to be attended to when they reach the facility. That's the third delay.
Thank you, Dr. Bagala. I will, starting with that very last delay, speak to Dr. Robert. When I paid attention to the statistics or the reality that we have more institutional maternal mortality rates, and especially at higher levels, hospitals and the like, than at the lower levels of health center 3s, health center 4s, I was taken aback, because at a higher level is when you expect to have the best of services. Why is this the case? Do we say that the lower health facilities refer the mothers in critical condition?
Thank you so much. And Dr. Bagala has been speaking to actually that especially the report, for example, shows that close to 60% of the mothers who die as a result of a delay at the community to seek care. So we lose many of these mothers because of that delay, which he has labored to explain.
So they come late to the facility?
So you can imagine a mother spending quite a lot of time struggling to make a decision on whether to deliver from a banana plantation or to go to and deliver from a health facility. So after losing all that time, then they struggle getting transport, to reach the health facility. At the health facility, of course, on the way, along the way, there might also be some delays accessing an ambulance or any other viable means of transport. So by the time they reach the health facility, one of the consultants at a regional referral referred to some of these deaths as sort of transferred deaths to the regional referral hospital.
Okay.
Meaning, and an analysis of these deaths shows that many of these mothers actually die within 30 minutes of arrival at the health facility.
So it's a late referral.
So
sometimes.
it's a very majority of them actually are late referrals. If you dive deep and appreciate, you'll see that some of these deaths can only be prevented if mothers, for example, can make the decision to deliver from a health facility early enough and then look for means of transport to these higher level facilities. And again, it's the same saying that I had colleagues mentioning that some of these high level hospitals like Chirudu, Mulago, they tend to describe them as death hospitals.
Thank you.
Because they get to know that almost whoever gets there, there are many reports of people who die from there. But what they actually forget is that clients or patients tend to waste a lot of time seeking for medical attention from actually non-qualified, non-professional people, so that by the time they get to Chirudu, actually they are dying on arrival. And that becomes a mortality statistic in the Chirudu report. So at the end of the day, there are lots of, it's this delay model. The delay at the home to decide where to deliver from.
Okay.
The delay to reach the facility, but also that delay. But Mildred, I wanted to speak to delay one,
No, doctor, just before you go to delay one, I will give you the time. Let's speak about this institutional mortality, because yes, you've talked about the delay that could be brought about by the mother. We will refer to them as a patient. But there is also the aspect of inadequate staffing. I personally have been to the obstetrics and gynecology department of Mulago. You will sometimes see mothers sleeping on the floor. You will see 3 mothers calling the same midwife at the same time.
Sure.
Are we speaking to realities of staffing levels, the people who will attend to the 2-in-1 that Dr. Bagala referred to?
Yeah, that remains a challenge. The population has grown, and I think it has kind of outgrown our old staffing norms. But I know that there is an ongoing restructuring, which started from the regional referral hospitals in the name of ensuring that the current staffing norms relate to the grown population. So there are efforts to increase numbers of healthcare workers, particularly targeting midwives, what they term as critical cadres. And I think the focus is now on midwives, and anesthetic officers, medical doctors, and I think a few other cadres that are described as critical. So you are right. The numbers of healthcare workers, the numbers are not enough.
And do we have this plan continuous? Because yes, the population is high, but it's increasing. So we will be much higher, even 5-10 years much later. Do we have a sort of continuous plan that the Ministry of Health is paying attention to?
Yeah, so during the restructuring, they have factored the aspect of the population growth rate. You know that recently, I think on Friday, I was listening in from the Director General of the National Population Council that the projection is that we'll be 71 million by 2030. And so that also speaks to many of what the healthcare system has to undertake if we, for example, do not reverse the rate at which we are growing as Ugandans. I hope you're
not talking about restriction to kids.
And
okay.
And so, yeah, that's factored in. But the other thing also that I wanted to mention is that in majority of the districts, they have undertaken what is described as a within analysis. Okay. That's a workload indicator for staffing needs. So the district health officers are able to sit with the teams and be able to actually understand the burden, the bulk of the work, so that they can redeploy in the meantime as they wait for the revision of the staffing norms, so that some health workers can be redeployed from facilities where they seem to be redundant to other busier facilities. So the issue of lack of adequate critical human resources is very key. Okay. And I think that is top on the discussions, including, I think, even it has already been brought to the attention of Parliament. Okay. to continue focusing on that.
You were talking about delay number 1
about as well. The delay number 1, the other thing that worsened the matters during especially the first lockdown was the fear of COVID-19. So many mothers, feared to get to these health facilities. And you know that when that pandemic had just been declared, a diagnosis of COVID-19 sounded like a death sentence. So if you had any of your colleagues, declared COVID-19 positive, I think somehow people would quickly think that, this so bad, too bad, this one is gone. So with that fear that came with the C-19, you see that many more mothers were hesitant to get to these health facilities for fear of contracting this deadly disease that at that time was almost, whose positive diagnosis was like a death sentence. Sure. I think that's something that also contributed to the low uptake of antenatal care and delivery from health facilities.
All right, thank you very much, Dr. Robert. Back to you, Dr. Bagala. Earlier on, you talked about bleeding. I'm wondering whether that's what you refer to medically as hemorrhage. As one of the causes, one of the leading causes of maternal mortality. But some of the statistics and indicators that we do have, I think also Dr. Robert will talk about this, shows a 3% reduction in hemorrhage related to maternal mortality, and that's from about 45% to 42%. But for a person out there, they've been pregnant, they probably have a pregnant relative, or are planning to actually have a child. What is hemorrhage? What causes it? I mean, are there any stopgap measures that a mother out there will need to look out for?
Mildred, if you can just allow me just to add a little piece to what Dr.
Please.
Robert has mentioned.
Please.
Because now, of course, a pregnant mother, there are different facilities in their structure of the Ministry of Health. And of course, we have Health Center 2s, Health Center 3s, 4s, the general hospitals, the regional referral hospitals. And we receive mothers for antenatal care from Health Center 3s, because normally the mother at a Health Center 3, there is a proper plan on how she's going to deliver. And I think, Dr. Robert, that's at the sub-county level.
Yeah, sure.
And efforts are being made to increase on these to turn Health Center 2s into
Many
Health
of them
Center
have been upgraded to actually Health Center 3s
Center
to
3s.
provide delivery services for mothers.
So one of the things that we are seeing is that mothers that could be potentially managed at the lower level facilities having self-referrals into the
Okay.
high level facilities.
I walk in myself.
Yes, I just walk in myself. And the quickest example is Kawempe National Referral Hospital.
Oh, yes.
Have you been there, Mildred?
Yes, I have, several.
Excellent. And you would see that we have, on average, we see over 200 antenatal care mothers, and we deliver over 100 mothers in a day. That's within 24 hours. And we operate over 40 mothers within 24 hours. So the
Wow.
rest are normal deliveries. It's the highest volume facility that I've ever known on this continent. but the cause of that is that mothers are now just moving into Kawempe and leaving the facilities that could still manage them.
Have you gotten deeper into why? Because it could also be access to the much needed facilities. I mean, everything you want has to be bought at the end of the day.
No, the issue is that service delivery has been strengthened at these lower level facilities within Kampala, the Health Center 3s, the Health Center 4s that we have, that these mothers should be able to access the basic obstetric care in those facilities. And then we allow the referrals of the cases that need to be managed in the facility, like Kawempe National Referral Hospital or the Mulago Specialized Women and Neonatal Hospital, to be referred by the clinicians. But and that's where, Mildred, we need to work very, very closely on sensitizing the community that there are those facilities that can manage them. Otherwise, the minimal human resource that we have in Kawempe has become so thin because of even the cases that would potentially be managed at the lower level facilities, and they end up just getting into Kawempe National Referral,
Okay.
and we get those mortalities, which at the end of the day compromises on the quality of service that we deliver. Now, back to your question, Mildred. So the issue of bleeding is very, very important. And I'm really, really delighted that out of the efforts that the Ministry of Health, so there is another entity which the Ministry of Health supported to establish, which is the National Safe Motherhood Expert Committee. And this was created because it was noticed that the ministry and the government of Uganda has trained many doctors, nurses, and midwives, but their contribution to improvement of care, aside providing the care, the clinical care in the hospitals, was a bit minimal. But we are also cognizant that these are professionals, the experts who have done PhDs in all these different spaces of preeclampsia, in hemorrhage, as you called it, in sepsis. They have a lot more that they can contribute to this sector from the policy perspective and other aspects of the health sector. So this entity was created, and I'm a member and as well coordinate that National Safe Motherhood Expert Committee. So the issue of bleeding, yes, out of those efforts, we looked at the analysis, and we saw that there are different causes of these mothers that we lose because of hemorrhage. And of course, when you look at when a mother becomes pregnant, the most amazing bit is that your blood circulation in the body changes. And of course, you have a prioritized blood saturation to where the baby is. And of course, that is to enable the baby to be fed quite well. And every single minute you have around 500 mils of blood every minute, getting to that womb where the baby is. Now, this increases for every single stage of pregnancy. And so, you know what it means if bleeding is coming from that point where the baby is. Every minute, you have 500 mils. 500 mils is that...
Is this bottle of water
exactly.
Yes.
So every minute you have around that volume getting to the womb, what we call the uterus in our term. So bleeding is very, very critical when it comes to us as obstetricians. Because if a mother starts bleeding and the interventions are not rushed, that blood that goes into the uterus will now be getting out of this mother's body. So when it goes to the uterus, where the baby is, it goes back into circulation and supports your brain, your kidneys, your heart and lungs, your limbs, and every single other part of the body. So you can imagine that you have that section of blood, instead of going back into your body circulation, it's just going out. What is going to happen at the end of the day? That you'll have deprivation or cut off of supply to some of your critical body organs. And then you'll go into things that we call shock if you have lost a significant amount of blood. So pregnant mothers have a risk of losing significant amount of blood if they bleed than non-pregnant mothers because of that change.
Is it medically caused, or is it an induced? Is it something that we can be able to prevent at the end of the day?
And it boils down to antenatal care, Mildred. Antenatal care is very, very important. Why? Because if a mother is between 0 to 12 weeks of pregnancy,
okay,
and that's where we encourage them to come for the first visit. Below 12 weeks, come for the first visit. And I think you would allow me, Mildred, to just run through this, how often the mother should be coming for antenatal care.
That's okay.
Yeah. So the first visit is below 12 weeks. Then the second visit, we expect a mother to attend the second visit between 12 weeks to 20 weeks. So that's within the second trimester. The first one is the first trimester. And now the third visit is between 20 to 24. Now you may say that, yes, but there used to be 4. Yes, there used to be 4. But as Robert will mention, that we've noticed that we are losing quite a number of mothers. And we think that if we had some contacts with these mothers for at least 8 times, would save more. So those are the contacts that I'm going to explain. So the third contact is between 20 to 24 weeks. The fourth contact is between 24 to 28 weeks. The fifth contact is between 28 weeks to 32 weeks. The sixth contact is between 30 weeks and 32 weeks. And then the sixth contact is between 32 to 36. And then the 8th contact is at term. So if the mother is pregnant, that's when we expect. And if a mother comes back and they have not yet initiated, their labor has not yet been initiated, we encourage them on when to return. So antenatal care is very important because we screen and see which mother is really at risk of losing a lot of blood. We check for your quantity of blood and say that, okay, fine, your quantity is slightly low for the safety of the baby and yourself. So we need to give you some medication that will prop up or increase on your blood levels. So we screen for all these risks, and we are able to guide on the mothers that will be able to carry a pregnancy to 40 weeks, or mothers that may not be able to carry the pregnancy to 40 weeks. So there are those different things that we look at. A mother who has been operated in the first pregnancy, the story a bit changes. Because if you had a cesarean section in your first pregnancy, you are different from a mother who wasn't operated. There are different circumstances that happen when you conceive for the second time, and we call them high-risk mothers. For a mother who has 2 or more babies, those are high-risk mothers. For a mother who's below 18 years, as we've mentioned, we have an increase in teenage pregnancy.
Sure.
Those are high-risk mothers. And one of the risks that we are looking at is that bleeding or hemorrhage.
Okay.
And the hemorrhage, of course, has different categories. Mildred, you know that. So you have what we call the antepartum hemorrhage, and you have the postpartum hemorrhage. So
Sure.
the antepartum hemorrhage is between 28 weeks and 40 weeks before you deliver, and then postpartum hemorrhage
Is
after delivery.
Okay, and you talked about aspects of cesarean, and we're talking about maternal health. One first question is the rising cases of cesarean I mean the rising cases of cesarean birth. Is it by choice? Is it by design that we're having more women having cesarean birth than the normal delivery or vaginal delivery? And also at the end of the day, Dr. Bagala speaks about a cesarean birth mother having a second, pregnancy being at high risk. And for many people, it's become fashion that if I got a C in the first birth, then it's entirely C all through for the children I would like to get. Is that so? Or can you actually have a C at first and have, a normal delivery later on? So two in one first. Why are we getting more C's?
If I may also come in there.
Yes.
Yes, so there are indications and medical indications for a mother delivering by a cesarean section.
Okay.
But of course, over time, we have reports of women who come to certain hospitals and request. And I think they are grossly misinformed because...
I don't want to go through labor.
Yeah, and I think that's a very bad... If there's any mother who is really listening in, it's very criminal for you to walk into a hospital and demand. And I know that the elite mothers who walk into some of these hospitals tend to, to behave that way. But and we've also seen quite abnormal C-section rates in some private hospitals. And of course, there are standard, even the World Health Organization has recommendations in terms of which proportions. If you're delivering 100 women, we would not expect to have C-sections go beyond 15% of the 100 women. But of course, you can walk into a facility, a hospital, and you find cesarean section rates as high as above 50% of all the mothers delivered. And of course, that's abnormal. But what I needed to mention here is that there are medical indications or circumstances under which a mother should be delivered by a cesarean section. But we continue to really kind of investigate and interrogate some of this data that comes through, especially some private hospitals that particularly have abnormally high C-section rates. But for the women, I think that's just one of the reasons that have been cited, that many women, I think, tend to put pressure. But I think they're also putting pressure on some medics that have also lost some, professional values.
Yes.
Because, I mean, there's no way you'll coerce an obstetrician like JP to just have a C-section because you're able to pay for it. And we highly condemn and discourage women coming in and, prescribing C-sections as their safest mode of delivery. Because then there are risks. One, there is a risk of anesthesia. You can react to the anesthesia which you've requested for yourself. But also, the moment you have that, that knife, that scissor, like you mentioned, yes, it becomes an automatic indication for the next C-section. So once you are delivered by a cesarean section, the safest mode of delivery for the subsequent baby is the C-section, according to the standards.
You're scaring us now. Can't I do a normal delivery much later on?
So if you request
Probably
for the first C-section, you're automatically requesting for the second one. And until you probably go up to, I think up to 4. I think after 4, then you may be discouraged, and So that's the discussion around C-sections, and but also we've been working hard to ensure that we improve the uptake of C-section so that the mothers who need C-sections should be able to deliver. And again, we've been grappling with health facilities that have low C-section rates. It means there are many more mothers who would need to benefit from the cesarean section as the safest mode of delivery. But for some reason or the other, they are unable, and many of them end up being mortality statistics, adding themselves their numbers to
Okay.
to the deaths.
All right, Dr. Bagala, still on cesarean sections. Yes, we've seen so many mothers who walk in, I have the money, I can be able to pay for it. Secondly, I don't want to go through this entire, labor stuff and the pains for the mothers who have said that. And other, thoughts that I couldn't be able to say on air. But what are the dangers in a C-section medically? The dangers in a C-section. I know that mothers who undergo C-section because of medical condition. Personally, I had preeclampsia and I had to undergo that. But what are some of those medical red flags that people need to pay attention to?
So the red flags may have two categories, if I may say. Just to add to what Robert mentioned, a mother who has been delivered by cesarean section, as I mentioned, is put in our high-risk category as obstetricians. That pregnancy, if she gets another pregnancy, we have to watch it very cautiously. But I wanted to ask which category. Is it before we make a decision that this mother should be delivered by
Both.
cesarean section? Both.
Yes.
So, so the first category, of course, may be quite in the judgment of the clinicians, but there are really some clear, and also known to, sometimes we've had cases, and we've had very interesting multidisciplinary discussions on the mode of delivery. And when you go to regional referral hospitals, you see this, that a mother can come in and she has a condition like, let's say, she has one previous scar, and that previous scar is, let's say, 18 months back. And of course, we have different studies that inform our plan of delivery for the next baby. And of course, as per the national standard, it shouldn't be less than 24. You shouldn't conceive within the 24 months of your...
After the first C.
So after the first C. So depending on the centers that you go to and the clinical hands that you're in, our national standards, yes, if a mother is below 24, that is called a short interpregnancy interval. Yeah. So we take that scar is still very fresh to sustain the pressures for the next pregnancy during delivery. So that's if it's below 24. But of course, there are other clinicians who will judge that no, if a mother, and based on the research that has been done extensively, that if a mother really conceives within the first year of her birth of the cesarean section, that's when we would consider that kind of discussion. So there are those different literatures or schools of thoughts that come in. But as per the national standard, is below 24. So now on this other category of, for us deciding, of course, the very first-time mothers, and you have, we assess, we take a thorough assessment. We look at the size of the baby, and we look at the potential of you as a mother to push. So if we see that there is any discrepancy in terms of the size of this baby, and we have seen mothers, first-time mother, and you're having a baby who is more than 4 kilograms. You're first-time mother. The chances of successfully pushing that baby through are quite very, very slim.
Low.
Very, very slim. So that category, our chances of delivering you by cesarean section are extremely high. And the other thing that when we do, when we are seeing these mothers during antenatal care, we do what we call an ultrasound scan, which is, of course, very common to our mothers around here. Ultrasound scan. Kativi. It's very, very important because before a mother delivers, we are able to ascertain, one, how many babies does she have inside. If it's more than 2 babies, then our chances of delivering you normally are extremely low. Now, the second one is, how are also these babies presenting? Because the presentation, so the presenting is, how is this baby coming? So sometimes you have the baby coming with the head down. Sometimes you have the baby just seated. Sometimes you can just have the baby coming with the shoulder. Okay? So there is what we call a normal presentation and an abnormal presentation that would really trigger us to say that no, you can't deliver normally, we shall deliver you by cesarean section. And also depending on how many babies that you have. So there are different things that we look at. But what I wanted to add to Dr. Robert Mutumba's point is that a mother who's delivered by cesarean section, and based on our statistics, that your chances of having sepsis after delivery and also suffering from hemorrhage after that cesarean section are far, far higher than the mother who was delivered normally. So the comorbidities increase very significantly for a mother who was delivered by cesarean section compared to a mother who was delivered normally. So we encourage our mothers to really endeavor, and if you have been advised that you can successfully deliver that baby normally, please endure that job. And no, when the mothers, of course, are delivering, of course, there is that pain. And different facilities have brought up measures to alleviate that pain during labor. But if the mother goes through that process, there is a lot of joy. After that, maybe being given to them in their hands. So we encourage our mothers, if your clinician, your doctor and midwife has really guided that you can deliver normally, please don't prescribe a cesarean section for yourself. That is more comorbidity to you as a mother.
I think for the mothers who are listening, our .com mothers who think, it's easier to deliver through a cesarean section than a normal one, you know what you normally say about a normal delivery or vaginal delivery. But I think we are hearing it from the practitioners, from the people who are well versed to give you this information, that please let your clinician prescribe which mode of delivery will be most safe for you, depending on which category you're in as a pregnant mother. We'll be taking a very short break. When we do return, the spotlight continues, focusing on delivery of maternal and child health services during this COVID-19 era. There are aspects of abortions, there are aspects of teenage pregnancies, and what other presentations there are on the negative side when we have younger mothers at the hospitals, all these health facilities. That and much more when we do return.
The pandemic, beyond the disease, has presented unprecedented challenges in delivering of services to Ugandans from all walks of life. With the seeds of success in every nation on earth known to be best planted in women and children, Spotlight UG this Monday, 11th of October 2021, focuses on the delivery of maternal and child health services during the COVID-19 era. On the
My home, I smile when I think of you, Uganda. My home. My home, I dance when I look at you, Uganda. My home, oh my Uganda.
I know with you I'll always stay forever. I know, because I feel that we belong together. My home, under the sun so bright, under the moon at night, on my heart. Mommy, oh my Uganda.
Hey, mama.
At MTN, we look forward to starting another exciting journey together to grow our home, Uganda.
Get vaccinated today so we can get closer to the normal way of life. Echa COVID-19 chija kugwa.
You know, you could just buy a new smartphone from anywhere in Uganda. Dial *175 *94 hash to activate their 100% double data bonus offer on weekly or monthly bundles for 3 months. Better yet, you automatically receive free 1 GB valid for 30 days. You are hooked already, aren't you? Enjoy 100% double data bonus from Airtel. Buy a smartphone from anywhere in Uganda and insert an Airtel SIM card. Dial *175 *94 hash to activate a 100% data bonus offer on weekly or monthly bundles, valid for 3 months. Dial *175 hash and select your preferred bundle to activate a 100% data bonus offer on weekly or monthly bundles, valid for 3 months. Airtel, the smartphone network.
Getting GoTV was the best decision James has ever made. Finding a good place to watch football was never easy, but it was costly. Until James discovered something big. Now he can finally enjoy the benefits of homegrown advantage with a decoder and 1 month of GoTV value. For just 25,000 shillings, enjoy the world's biggest leagues and cup competitions. GoTV Uganda, love it.
Uganda, today is a great day to work towards your dreams. Dial *185 *7 hash and select savings to save as low as 500 Ugandan shillings on regular savings or 250,000 Ugandan shillings for fixed deposits. Airtel Money Super Saver is powered by KCB Bank Uganda. Airtel Money, instant, secure, borderless. T's and C's apply.
On the journey of AGOA, one of the things that first happened was to train over 2,000 girls.
So there were many problems for investors at the time I joined Uganda Investment Authority. And our role was to identify them, go to government and say, you've got to change this.
In 1986, we had about 2,000 kilometers of what you would have called paved road, but in very sorry state.
I want to thank UBC that enables us to get these very important messages.
Showcasing where we were and how far we have come.
The Kalanga Infrastructure Services Limited, we signed an implementation agreement where we are running 2 ferries, we're generating and distributing power to the entire Bugala Island, supplying clean piped water.
Even Enterprise Uganda, we started with 5 people. Today we're all over the country. When you are approached by UBC,
every week,
please make time and offer us the benefit of knowing where you came from, what you are doing, where you are headed to, so that we can all appreciate that things can be done.
Switch to Airtel, Uganda's only 100% 4G network, and get 50% data bonus on all bundles purchased using Airtel Money. Visit the nearest Airtel shop with a valid national ID to buy a SIM card today. For business entities, please share an email with business.support@ug.airtel.com. Enjoy the best rates on calls, SMS, data, and Airtel Money across Uganda on your preferred number. Subject to availability. 50% data bonus is valid till 15th November 2021. Airtel, the smartphone network.
It's no secret that
the COVID-19 pandemic, beyond the disease, has presented unprecedented challenges in delivering of services to Ugandans from all walks of life. With the seeds of success in every nation on earth known to be best planted in women and children.
Dr. JP Bagala, who is a practicing, his field is obstetrics and gynecology, but he is also the executive director of Women's Health and Research Institute. Gentlemen, as we took a break, we were talking about, delivery and my choice, whether it's going to be C or it's going to be a normal delivery. And there is the aspect of rights. As a client, I consider myself a client to the clinician. I have my rights. You will have sometimes to take what I desire, not what you want to. Now that brings into question the balance of your ethics and medical profession vis-a-vis my rights as a client. I want us to talk about it both, and I'll start off with you, Dr. Robert.
Yeah, so of course now the global focus is on respectful maternity care. And of course, in respectful maternity care, you want to put the client, you want to put the mother
at the forefront,
at the center. But the clinician has to strike that compromise, that understanding. And in my own opinion, the clinician is actually supposed to deliver a service according to the standard. Of course, when you talk about respectful care or quality of care, we mean that service that will meet the expectation of the client, who is the mother. But we normally add the word, the reasonable expectation, because some clients tend to have some expectations that are not reasonable. And I think a mother walking in and requesting for a cesarean section is one of those unreasonable expectations from that client. And therefore, the clinician, the doctor has to stick to the standard. What is the indication for this cesarean section? In fact, in some of these hospitals, if you dive in and ask, what is the indication? What is the basis for delivering this mother by a cesarean section? I think it might be tricky because the doctor cannot document that this C-section was done on request by the client or by the mother. So I think, yes, as much as we are talking about respectful maternity care, quality of care, putting the mother at the center, I think the clinician should get it clearly that the quality of care should be really in tandem with the standard and not necessarily. And again, Mildred, I can give an example of a client who works in the OPD clinic, and he or she has a fever. You do a lab test for malaria and the test result shows negative. But the client demands for Coartem.
Because I feel feverish.
Yes, yes. So somebody demands for Coartem. Even when now and the national standard says, do not give any anti-malaria to anyone who tests negative, either by microscopy for malaria or through any of these rapid diagnostic tests. But the client may not feel happy if you didn't give them Coartem. And for me, I wouldn't definitely give you Coartem, but of course would definitely require that the health worker takes a comprehensive assessment for this other, for the client, to establish the cause of the fever, whether it's a urinary tract infection, whether it's due to other causes of fever like typhoid, or so, other than really just. So in this, it would be very unethical for a clinician to just do a C-section just upon a request by though sometimes I think the situation sometimes get tricky
when you have a political patient,
when you're dealing with a political client.
We'll get away from that discussion, but I think it is well put that you need to follow the guidance of the clinician. Coming to you, Dr. Bagala, we are in a COVID-19 season and we are accelerating vaccination. There have been lots of myths and misconceptions about vaccination in pregnant mothers. Could you clear what we've been hearing or what is shared across social media? Deformities in babies, you will have these, a stillbirth, and stuff like that.
Thank you very much, Mildred. And yes, I think we've received quite very many questions from our the pregnant mothers who are breastfeeding, and the mothers-to-be, or mothers, women who are planning to get pregnant, around the issue of COVID, and also now currently that we're encouraging all Ugandans to get vaccinated. And as we are all aware, COVID is a new disease in our midst. This particular type that we have, there are different types that have existed before, and that's why it was quick for us to have this vaccine developed, because there is just a change in strain. But we've had other coronaviruses before, so it was quite quicker for us to, for the scientists to expedite the production of this vaccine. Now, there is a lot of research that is happening, even at this moment. ever since COVID started. And in our space, of course, we looked at what is the effect of this COVID in a pregnant mother, to the mother herself, and to the baby. And what is its effect to mothers that have just delivered? The findings that have also been backed with the current statistics, because every single day more findings are coming in, is that a mother who's pregnant or a mother who has just delivered, if they contract COVID, their chances of having critical disease, and critical disease we mean a mother or a patient having COVID and going into ICU. That's now the critical stage of the disease. So the chances of pregnant mothers and those who have just delivered progressing into critical disease are extremely higher than for non-pregnant mothers, or for the non-pregnant clients or patients. So pregnancy alone is a risk indicator for severe disease in, for COVID patients. Secondly, ever since the vaccination started, a lot of still research has been done on finding what is the effect of the vaccines, all the certified vaccines, the approved vaccines. And in that we are talking about all the vaccines we have in Uganda now that are being delivered. AstraZeneca, Pfizer, Moderna, Johnson & Johnson, the Sinovac. So all those vaccines are certified by the World Health Organization to be given to humans, and they have gone through all the approval processes. So a lot of extensive research has happened still on the effect of these vaccines to the pregnant mothers and the babies. And it has been discovered that there are no risks that have been mentioned before regarding vaccines that have been registered in pregnant mothers, in mothers that have just delivered, that means lactating mothers, all those who are planning to get pregnant once they receive the vaccines in their full doses. Those risks have not been registered at all in all the studies that have been conducted. So it's based on that research, and in science or health, which is a science, we base a lot on research. And what is this research telling us in terms of evidence? That evidence to inform our care. Yeah? And Robert will tell you that of late we are encouraging evidence-based care or evidence-based practice, where we are saying that can we use our scholars at Makerere, at Mbarara, Gulu, Busitemba to inform our practice. So based on the research that has been done, no risks have been registered in the categories of pregnancy. And that's where we encourage mothers, pregnant mothers, to go and get the vaccines. Because if you don't get the vaccine and you're pregnant and you get COVID, your chances of going into ICU are far, far higher than for a non-pregnant client.
Okay. I think that's very clear. The only risk is getting it and when you've not been vaccinated. And just to remind you, as always, that vaccination does not protect you from getting COVID-19. However, it does protect you from slipping into the adverse, critical conditions of COVID-19. Dr. Mtumba, let's talk about contraceptive uptake in Uganda. Because when we're talking about maternal services, like you said, it's from the time that I am thinking about getting pregnant all the way through the period, and also the aspect of planning. How many children do I want to have within which particular interval? What are the statistics currently on family planning uptake? And also remembering that during the COVID-19 era or lockdown, around the months of February, April, there was a bit of a blimp in contraceptive uptake. Have we sorted that out? And what's the continuous plan that we continue with it even when we have such coming through disruptions?
Yeah, so in terms of contraception uptake, there has been some registered progress, but we are still, I should say, we are still doing not very well, because we had, as a country, we had made commitments, what we termed as the FP 2020 commitments, where we really had to significantly increase the uptake of contraceptions. But I would like to mention that as a country, we seem to be sitting on a time bomb, especially when if you read, I have a copy of a report here entitled The State of Uganda Population Report 2020, which projects our population to be at about 70 million by 2030. So it means that if we continue to have very high fertility rates, which of course we stand at a rate of 5.4%, it means that as a country, the resources that we have will not be sufficient to cater for the growing population. And of course, people tend to mention that what's the problem with the big population? And I want to state that there is no problem with the big population. But the problem is with the population growth rate. And I think the key word there is the rate. Yes, you see that if your population grows at a rate that is much higher than the resources can handle, then you're in a problem. That's why in a typical home, if you, for example, have a delivery of 3 babies, when you probably planned to prepare for 1, it's going to be a problem. The problem is not the 3 children or the 3 babies. The problem is that the 3 babies have come too fast at a rate that you cannot handle them. And so we are still low in terms of contraception uptake. And in Uganda, I think we have we are among the countries on the African continent with the highest fertility rate. Fertility means women who are really fertile, and in a lifetime, they are putting us at 5.4 means roughly a woman can produce up to 6 children.
Wow.
If I round that off to, of course, the journey has been long. Looking at where we've come from, the fertility was high as 10 plus. If you look at a trend of 15 years ago. Yes, so there's that reduction, but the reduction is slow. We need some acceleration. And looking at the context of the COVID-19 pandemic, in March and April 2020, we had a very significant drop in the uptake of contraception. And I think that's the lowest drop ever when you ever recorded. Because, of course, there's that disruption in terms of movement restrictions. But effective June 2020, we recovered. We seem to have recovered. But of course, when you look at the issue of unwanted pregnancies, it's actually not just among the teenagers. Even among, if I can term them as adult women,
yes.
Through this pandemic, we've seen lots of women actually conceiving when ideally they have not planned to conceive.
They were locked up with their partners.
Locked up with their partners. That could be one of the reasons. But because of this, very many unwanted or unplanned pregnancies, we have seen a corresponding increase in the rates of abortions. Usually individuals who tend to abort, that scenario normally arises when the pregnancy is unwanted. And so it's not surprising that there has been some increase, including maternal mortality associated with abortions. And so, again, when it comes to the teenage pregnancies, definitely I think the pandemic has come to prove that just keep the girl out of school, and then the next thing she'll be pregnant. So, of course, the issue of girls being out of school, the issue of access to information on contraception among a wide range of, age groups, not only the teenagers, has actually contributed. And when you look at these death reports, abortions contribute. I think they now stand in the 4th position in terms of the leading causes of maternal deaths in the country. And so we continue to lose many young but also mature women through complications due to abortions.
Okay.
And all that is due to really the limited access to contraception services, which of course through the lockdowns there could be access issues. But again, there's been a lot of effort in terms of building a capacity of health workers, first of all, to be able to provide a wide range of contraception services. That has also been a challenge. If you come to a health facility and a health worker has gaps in provision of certain methods, the health worker may not be able to provide that comprehensive counseling, family planning, education counseling, because they fear that if I do not know how to insert an IUD, an implant, and then the mother ends up accepting that, then the health worker will be in trouble.
Okay, thank you very much. Back to you, Dr. Bagala, and I will also take it back to the patient rights. Contraceptive uptake. Some have the access, but they've just refused to use these contraceptives because of lots of myths that have come through. Through the research that you have done, what do we attribute to the low contraceptive uptake, whether it is regional or in particular areas? And also the second bit is about me deciding, the girls who have started taking Postina or whichever pills because they are preventing a pregnancy, self-medication. I want us to speak to that. And also to self-medication is a friend used an IUD and I come to you, doctor, and I say, I want an IUD, even when you have prescribed something different.
Yes, thank you, Mildred. And yes, a self-prescription is not something that we encourage at all. I think we've seen that on in the cesarean section, that please don't self-prescribe for yourself a C-section. Anywhere, provided it's a medicine, family planning as well, we encourage. However small that method is, it may not be safe for you as an individual. So we have what we call the eligibility criteria and the medical eligibility criteria. And this, we look at different women who come to us seeking these methods. We are supposed to take comprehensive history. We're supposed to ask you a series of questions to be sure and advise you on what method is suitable for you, based on your age, based on your fertility desires, and also based on any other possible medical conditions that you may have. So it's not that every single family planning method is safe for everyone. And as you know that we have the short-term methods, we have the long-lasting reversible methods, but also we have the permanent methods. So if a woman comes, and I really encourage our listeners that before you go to any pharmacy or dispensary to get yourself any method, and it's mostly common, as you mentioned, Mildred, for we had some bit of fun and accidentally we either the condom broke, as we get these explanations from our clients. If you really think that something happened that may lead into a pregnancy that you have not prepared for, we encourage you to first go to a health worker.
Time.
Yes, and there is
we were talking about delays earlier on.
Yes, and there is that allowance. The interesting thing, the way the physiology of pregnancy happens, depending on at what point have you had that session of happiness in view of vis-a-vis to your body as a mother or to your cycle as a mother. But there is allowance of 72 hours. Okay. For this common method, as you've mentioned, the Postina one, that people really buy so commonly, there is that allowance of 72 hours. That beyond that, the chances of conceiving are very high. But of course, for every single 24 hours that increase without quickly responding to that aspect that might have happened, your chances of conceiving increase. So because of that criteria that we use to select which method is suitable for which woman, not all methods are safe for all women. And that's where we need our clients, our mothers and women who are listening to us, to get to the health workers, take them through, and we shall advise you on the best method. But the other thing I also wanted to encourage are our pregnant mothers. Yes, talk about family planning in your antenatal and ask those questions. Ask the questions to the midwives. As you attend antenatal, we get quite a number of mothers, and the mothers is having 4 cesarean sections, and she's on the operating table. And you really, when you perform an operation, you see that really if this mother gets another pregnancy, her life will be in danger. And then you ask, did you try to talk about family planning? Because before a mother takes any of these methods, you are given the rightful information. And that's what Dr. Robert was mentioning. Information is very important. That as clinicians, we give you all this information and we enable you to choose a method that you think is comfortable for you, considering that there are different methods. So mothers who are pregnant, also talk to your clinicians that see you during antenatal about family planning. The mothers who have lost pregnancies, unfortunately, there is also a time that we look at that if a mother has had an abortion, what allowance can we give for this womb to be ready to hold another pregnancy?
Yes.
Not again immediately conceiving right away, because the womb may not be prepared. And what comes in there is for us to guide you on what method that you can use. So we encourage mothers to talk to us about family planning. Don't fear to ask us any question about family planning. The misconceptions are what we are getting commonly. That, if I have these methods that we put into the uterus, which we call the intrauterine contraceptive devices, that, maybe when I conceive, it will get into the baby's body part. All my chances of getting a pregnancy within the tubes will increase. So there are those misconceptions. It's giving me this very bad, abnormal discharge down. But there are different methods, and we're able to counsel you how you can have some of those body reactions to these methods addressed. But yes, we agree different methods will act differently in different bodies of the women.
All right. Thank you very much. You also talked about, Dr. Robert, the aspect of, because of teenage pregnancies that have come through, a bit of a rising rate of abortion, although also maternal deaths due to abortion complicated issues before COVID were a little bit going down, reducing from about 8 to 7%. Talking about abortions in the country, of course, we know it is not allowed. It's against the law for an abortion to take place. But are there any medical abortions or medically approved abortions that could take place? And when we're talking about this delivery, I mean this reduction in abortion rates from 8 to 7% before COVID, do we say now people are having much more safer abortions than the unsafe ones that existed before?
Yeah, so the context, the full context of the law in regards to abortion, like you've clearly mentioned, is clear. But of course, you mentioned that medically are there circumstances. And of course, I think there has been a lot of confusion. Confusion, because there are medical indications that that clearly when you get into the law, I think the health workers also get confused because you can hear of scenarios of gross congenital abnormalities that are not compatible with life. For example, if you JP did a scan and you see that what the mother is carrying in the uterus is actually not a human being, and you know it's something like, I don't know how actually to describe, but it's not a human being. And so there are also scenarios where the woman's life is actually practically in danger, and the practitioner wants to terminate this pregnancy in the interest of saving the mother's life. But of course, when you look at these laws, I think what I need to mention here is that there's still a lot of confusion And so sometimes the health workers, I think, just get confused, because even a scenario where you have a baby with gross congenital abnormalities, I don't know what Dr. J.P. Bagala's experience could be, and in terms of whether he views that he is protected by the law to
or do we need to take back the law to Parliament?
Or terminate that particular sort of a pregnancy. And I think maybe JP can come in here and share his particular experience. But I think that's the kind of confusion for even some of the conditions that practically may put the mother's life in danger. I don't think it's also clear that you can easily get to terminate this baby. I don't know whether there are scenarios that you can cite.
I think Dr. J.P., please.
Quite controversial.
Or do we need to push for the law to go back to Parliament at this point in time?
No,
medical abortions.
Yes, we've come across quite a number of cases where, as Dr. Robert mentioned, in situations where the mother's life is in danger. In such cases, or if the pregnancy that is being carried in our discussion and judgment, we are sure that really the outcome of this pregnancy is not going to be appropriate. But also there are other medical conditions that we look at, as Robert mentioned, that and that's where the importance of CATV becomes very important. Because there is that initial, the common one that we get. We know how pregnancy is a time of joy or a period of joy to many mothers, and they would really want to have a baby out of that pregnancy. But also there are conditions that we look at that happen in circumstances where when the man's or the husband's egg united with the mother's egg, what formed out of that is not a baby that would really be delivered and the family would be happy about. So we sit the family down after us identifying the condition that we have got and agreed. And in majority of the facilities now, it's a team approach, where if I'm a junior clinician, if it's a midwife at a health center 3, then they would need to refer that mother to a health center 4, or a general hospital, or a regional referral hospital. That's if the mother's not gone there straight. So the team sits and discusses that, okay, fine, we've done this particular scan, and we've noticed that the mother here, the baby has no brain, because we have those circumstances. Or the baby's limbs are extremely off. We've had those circumstances. And you have to sit the mother and the family down and counsel them. Because there are also pregnancies that have been carried forward, and really it's not going to bring joy to this family. So, and it goes back to what I mentioned in safe motherhood, that in safe motherhood, we are looking at the proper outcome of the mother, the baby, and the family. Our aim is that joy going to exist in that family if they are having the product that has come out of this pregnancy? We counsel the family, the mother, and then the family, and we make a comprehensive decision. We offer our plan of management, and of course in our space, medically the law allows us to guide on the proper plan of management, that if we think there is need for us to terminate that pregnancy, we shall do the needful, but the consent of the mother and the family is very, very important before we proceed. But of course, we are also aware, and the close to 13% mortality due to abortions that we have, as Dr. Robert mentioned, it's because of abortions. And we know that we are getting lots of these teenage mothers into our clinics that are bleeding. They come to you bleeding. And when you do your necessary examinations, you realize that, oh, she was pregnant, and then this pregnant was terminated, whether by herself or by someone, or it just terminated itself. because those are different circumstances under which that pregnancy can be terminated. So we also get those cases. And of course, the conversation that are happening right now is that the allowance we have in our jurisdiction is that we have to attend to that mother and provide what we call the comprehensive post-abortion care. So we have to ensure that we save that life, we have to ensure that we counsel on family planning, and we have to ensure that we address any issues of stigma that may be surrounding the aspects of having lost a pregnancy.
Okay.
Now, where your question comes in, Mildred, and which is a matter of contention, is that if I'm a mother, I have a very healthy pregnancy, and it's at 12 weeks, and I need to terminate it. That's where we have the legal contention that as per the law, we don't have that allowance.
Okay.
And of course, we are supposed to guide you. And we have received many mothers as well who have come and they want to terminate these pregnancies. And we have counseled many who have, at the end, carried these pregnancies to term.
Now we understand the reason why you are supposed to move on to go to a hospital, go to a health facility and receive medical attention and advice. Coming back to you, Dr. Mutumba Robert, teenage pregnancies, that's the talk right now, COVID-19. But even before the COVID-19, although that has skyrocketed the discussion about teenage pregnancies, we know there are a number of complications that come up with, younger mothers. Like you said, they're a high-risk category at that point in time. But some of these young mothers have probably not gone to the health facilities. One of the reasons they've given is that they do not have friendly health services. You have a 14-year-old attending antenatal with a 40-year-old, and you are expected to be given the same services. What is the Ministry of Health doing about this?
Yeah, in that regard, the Ministry of Health is rolling out, it's called a group antenatal care model. That group antenatal care model ensures that these young teenage mothers are picked up and attended to in a kind of, like you rightly put it, if you have a 15-year-old, teenager who's pregnant, and on this side you have a 40-year-old who is really an expert mother, if I should say so, she will not be quite comfortable. So what the ministry is doing is to really innovatively scale up models like the group antenatal care model, where you have these teenage mothers in that kind of a similar age group attended to. But also, we are also embarking on ensuring that healthcare workers' capacity are enhanced in terms of being responsive to the needs of these young teenage mothers. Of course, at that time, this girl at the age of 15 is pregnant. It means there's nothing more that you can do. If it's an evil, if it's a sin committed, it's already committed. The only thing now you have to do is get to what JP terms as the safe motherhood. How do we ensure that now, if we failed to actually prevent pregnancy, this time around, how do we ensure that this young teenage mother safely goes through pregnancy and childbirth? And so there's been lots of capacity enhancement for health workers to stop really, questions like, at your age 15, you're supposed to be in, probably, I think, right now they don't ask school, but like you're not supposed to be here in the labor suit. What are you doing here? You're
and
spoiled.
those questions keep them away because they say the medics keep asking, what were you doing? What did you expect? And that keeps them away.
Yes, and of course at that point you have nothing much to do. But the best thing you have to do, the question is, how do you ensure that this teenage mother safely goes through this pregnancy and childbirth period? And so building capacity of health workers to become responsive. Some people use the term friendly to these young people who've already messed up, for lack of a better word, I think is what is ongoing. And this is always a call for these health workers to be able to physically, but also psychologically, provide these services to these young people who are already pregnant. And so it's two-way. It's speaking to health workers to have this sort of a customer care to these young people, and ensure that they feel comfortable, but also rolling out models like the group antenatal that I mentioned, so that the young teenage mothers find this kind of pregnancy and labor, an interesting experience, but also ensure that there are talks around family planning, because studies show that a teenage mother is more likely to actually become pregnant when she's still a teenager. If she conceives at 15, she is more likely, if you don't disseminate more information, and actually, before she leaves that teenage category, she's more likely to have another, conception. And so those are some of the packages. And we have high impact interventions and priority practices that the ministry through facilities are rolling up. And among those include family planning, because a 15-year-old who has conceived, if you do nothing, she is going to conceive again. So discussions and conversations of family planning are very pertinent.
Okay.
And those are some of the things that are ongoing.
Still in the era of COVID-19, lockdown, or, we thought being at home was the safest way. But then we realized, even in police reports, that we had higher cases of domestic violence. Violence against women and girls became very key. Some of these were pregnant mothers. Some of these were probably expectant mothers. And Dr. Bagal, I want you to speak to domestic violence or violence against women and girls in the context of maternal and child health services. What have been the statistics? What has research shown?
Thank you very much indeed, Mildred. Of course, domestic violence, we are cognizant of the fact that the cases are on the rise, as you've mentioned. And one thing that we pointed on as we're beginning was the critical role of men when it comes to maternal and newborn health.
Exactly.
That it's not only the mothers and the babies, but the men are a very, very critical piece to us improving on maternal and newborn health. And sexual gender-based violence is one of the key components where we need to engage the men quite very, very strongly, because they have been seen as we men. we are on this call as men. So it's we men, I should say, that we've contributed quite significantly to those numbers rising. But also, Mildred, we know that health is not just absence of disease. You are looking at the social, physical, and mental well-being. And in addition to that, for a successful pregnancy to be carried forward, there are aspects where, and that's being carried to term, where a mother now reaches 40 weeks and delivers as expected. We've seen pregnancies where mothers are delivering before they reach their expected date of delivery, before they complete the 40 weeks. And one of the contributors is if these mothers are not given a conducive and comfortable environment psychologically. Stress is viewed as one of the triggers of what we call preterm labor. So it's one of the triggers. And that acts within your body as a pregnant mother, and before you know it, the waters are breaking. Before you know it, you're getting into labor pains. When you're 30 weeks, we are 28 weeks. When we are 34 weeks. So one of the things that is leading to the stress is definitely what's the environment that this mother is living in at home. How supportive is the husband to this mother who is pregnant, to ensure that we have that triad, the triad of the baby, the mother, and the husband or the father. So it becomes very important for that triad to be complete. Now, the other thing, of course, gender-based violence, we have received quite many cases of maternal deaths that are resulting from the mother and the husband got involved in a fight. And at the end of the day, this mother, the pregnancy was affected. There is a condition we call abruptio. So you have separation of the placenta before the baby is delivered. And that happens whenever this pregnancy is hit, or the mother has any aspect of trauma on that pregnancy. And we've seen quite a number of cases where those pregnancies, where mothers have lost their pregnancies out of those sort of conditions that they have gone through, or fights that they have gone through with their respective husbands. So at the end of the day, there is no joy in the family, and there is no joy for us to have the fulfilled aspect of safe motherhood. But also we are looking at mothers as being the centerpiece to a peaceful and developmental society,
Oh, yes.
as you know, Mildred. And at the end of the day, if we have these mothers out of these equations, definitely, it becomes very, very difficult for the mothers, the babies that they are leaving behind, the children that are being orphaned. And those are the families where the husbands now have gone around to look for other women and what have you. And at the end of the day, it's a
also
broken
a different
family, it's a
story.
broken society.
Oh, yes.
So family remains the centerpiece to a successful community. And that family, you're bringing the children, you're bringing the father, and you're bringing the mother. And we encourage, if you really have any issues amongst yourself, marital issues, if talking amongst yourselves is not good enough, still, within the health facilities, we have safe corners that really offer these kinds of discussions. And we have taken quite a number of couples through a lot of counseling. And through the WHO, some of these sexual gender-based violence centers are being established, one at Women's Hospital, to ensure that we support these couples through some of these challenging situations.
All right. Do not solve whatever discussion you have with the fight. It doesn't help at the end of the day. When, Dr. Mtumba, when we talk about mortality rate, we do have different types. We've heard about perinatal mortality. We've heard about a newborn mortality rate. What are these, if you could break them down easily for the, people watching, and also what can we attribute to perinatal or newborn mortalities, and how can we be able to avoid those?
Yeah, first of all, mortality means death.
Simple.
It's just a big
It's just
jargon,
a beautiful.
Yeah. So mortality means death, and beginning with maternal mortality, maternal death. Of course, it's basically in simple terms, the numbers of women who are dying due to pregnancy and its related complications is basically maternal mortality. And so for Uganda, according to a report published in 2016, what we call the Uganda Demographic Health Survey report, in simple terms, it put us losing about 16 women due to pregnancy-related complications per day. But of course, we have an upcoming demographic report survey. Every 5 years, we do that report to try to understand the numbers of women who actually die due to pregnancy-related complications, both at the health facilities, what he termed as institutional,
yes,
but also in the community. So that's what the demographic survey looks at. And I think it might be happening this year or early next year, and the UBOS will do that. But every week, the division of the reproductive and infant health division at the Ministry of Health decided with a team of key stakeholders working together every Thursday to understand the burden of these maternal deaths on a weekly basis.
Okay.
Mildred, what seems to be coming out over the past 38 weeks, we see that institutionally at the health facilities, we have between 15 to 20 mothers dying per week. That's what is reported. And of course, when you look at that compared to the 2016 report, it gets us, it speaks to progress, because if you do 15 to 20 by 7, you have about 3 to 4 mothers institutionally. But I think when we undertake this demographic survey where they also capture the many of these community deaths, we'll be able to have a deep understanding of where we are. But just maybe to let the viewers understand the target, the Sustainable Development Goal, by 2030, we want to achieve less than, of course, we say 70 per 100,000 live birth, but that speaks to not losing more than 3 women, when I calculated, That's the target, that as a country, we should not be losing more than 3 women per day due to pregnancy and its related complications. That's basically the rates around the maternal deaths.
Okay.
But when we get to what we term as, of course, there's a term perinatal. Perinatal is also more complex because it's a category of newborn deaths, but also the stillbirths, the babies that die either before delivery or shortly after delivery. And so for the newborn mortality, these are babies that actually die within 7 days of delivery. And I think that's our calculation on the newborn mortality speaks to. And so we, as a country, we still have quite high newborn death rates. And the target, and I think in the report that we are yet to publish, you see that's quite a significant number of baby deaths. But we have seen a reduction, quite a significant reduction in the early neonatal mortality or the newborn deaths. I think I don't want to preempt the report that is yet to be published, and I think we'll be ending with that. But also when it comes to the stillbirths, there are those which we call macerated, those who die within their mother's wombs before they are actually delivered, for either due to malaria, syphilis, or many other conditions. And also the fresh stillbirths, the babies that actually die around the time of delivery. So the rates, we are glad that over time, looking at the country's trend, there is a downward trend in terms of mortalities. Of course, what we need to do is to accelerate the progress towards achieving the targets that we want to see. But overall, we are seeing this reduction in the mortality or the death rates across all this.
Borrowing one tagline of a political party, steady progress along that line, maybe. Our time is really fast spent, but before we go, Dr. JP, traditional medicine versus, what we would call, advanced medicine. And when it comes to maternal and child health, we've heard about so many, traditional drugs or medicines that women will take while pregnant to either ease a birth or be able to get a good health of their children. And this has been part of ours for quite a very long period of time. What is the relation? What are the do's and don'ts? What have the studies shown?
Yes, I thank you, Mildred. And of course, I'm conscious that our time is fast spent, really. Very importantly, that anything that is called a medicine, it's in our medical language or medical fraternity, it's a poison unless it's given to the body in the rightful quantities for the rightful purpose. Now, of course, the traditional medicines that we have, they are really good, but there is more that we need to do about them in terms of quantifying those components or the chemicals that respond to the disease, to ensure that if a patient takes this particular medicine, it's given in the rightful quantities. It's not going to affect the liver of that patient, it's not going to affect the kidney, and it's not going to affect the baby. And as I mentioned, that whenever we are giving any drug to a pregnant mother, we are not only looking at the mother alone. We are looking at the mother and the baby. So every single medicine, and the medicines that we have within our world, the modern medicines that we use mostly, you find that they are prescriptions that we make. And they come in particular doses. And you'll find that if I can give this particular medicine, let's say, if I can give 2 tablets to a non-pregnant mother of that same medicine, if the mother is pregnant, I can't give 2 tablets. And the reason is that I'm cautious of what's the effect of that dose to the pregnancy and to the mother as well. So it becomes very important, and we encourage that for the pregnant mothers, yes, don't self-prescribe any sort of medication. Please ensure that you take medicines that have been prescribed by your healthcare professionals,
Okay.
in line with whatever condition you present with.
Still talking about tradition, in the last few, Dr. Mtumba, traditional birth attendants have been with us for, I don't know, forever. And there seems to be a shift from, the traditional birth attendants to go and see a medical personnel. And probably this is the reason some of the women, especially in the rural areas, are not coming up. Do we have any mechanism where Ministry of Health could probably work hand in hand or train or retool these traditional birth attendants to be able to get incorporated so we will attract more people? Case in point, I visited one health center. It's called Lunyo Health Center, I think. And they've brought the traditional birth attendant to the health center. So you will have mothers come to the health center to meet the TBA. And in that way, they're able to deliver at the health center than at home with just a traditional birth attendant. Are you thinking about incorporation?
Yeah, so basically what is happening, of course, evidence showed that traditional birth attendants are traditional and they are not skilled attendants at birth. And so that's why...
But they were delivering our mothers at the end of the day.
Yeah. So, yes. But of course, there are quality of care issues that sometimes they lure some of these mothers and tend to act like, But I think what's happening now is converting them into traditional birth referral agents.
Okay.
So that they can... I think that's in line with what you're talking about. How can we engage them to actually refer more mothers to the health facilities? Because what happens medically is that they are not able to save a mother in the event of a complication, but they can actually attend to a normal... Just like I was having a chat with one of the ambulance drivers, somebody who has been driving, referring mothers referred to higher level facilities for delivery. And this guy has delivered about delivered in quotes about more than 40 women in the ambulance. And these are normal deliveries. And so he can easily claim to be a birth attendant. But labor is really natural. And so many of these actually, in the event of a complication, definitely evidence shows that they can't save the life of a mother, but they can only receive a mother like any other person who is not skilled can. But what we are doing is really transforming them into traditional referral agents. That way we can have many more mothers, but we are also working on improving the quality of care, the customer care aspect among our midwives at the health facilities, so that they get more friendly, but also be able to provide the wide range of respectful maternity care services.
Okay.
That
Thank you.
we need.
Thank you very much. I'll use the last 2 minutes split between the two of you. Dr. J.P. Bagala, your concluding remarks, and do we have a time when as a country we can have a sort of maybe conference and we talk about these issues, as opposed to only when there is an issue then we come in the media and we have to talk about this, these ideas, but as you conclude as well.
Yeah, thank you, Mildred. And of course, I think we have looked at some few points here as take-homes to our viewers. One, as soon as if you're a lady and you miss your period, please visit a health worker for us to be sure that if it's a pregnancy, we start you or we cancel you on the rightful processes. If you're a couple and you're planning to have a baby, still, before you conceive, visit a health worker so that you are prepared for your rightful pregnancy. For a pregnant mother, please deliver from the health facility. It's safer than within the community where you are not in the hands of a skilled birth attendant. And of course, as you mentioned, we have the National Safe Motherhood Conference, which is coming up on 28th and 29th of this month. So the preparations, the Ministry of Health is the lead host, and the National Safe Motherhood Expert Committee are the co-hosts. And we have a series of partners that really want to thank UNICEF, WHO, Population Service International, World Vision, Pathfinder. They have come in to support USAID, UNFPA, have really come in to support this conference. And the purpose of the conference here is for us to gather as a country to look at safe motherhood. It shouldn't be a complicated term. It's how do you become a mother safely? And for us to see the joy in you, the mother, the baby, and the family at large.
All right, and the next media conference center is here for the conference to go on. And of course, we'll as well be able to broadcast it live. Dr. Mtumba, let's come to you for your closing remarks.
Yes, thanks. And mine is a call to action for leaders, cultural, political, religious, technical, for us to be able to really sensitize the public. And I think the other challenge we are facing is misinformation, and misinformation tends to spread faster, much faster than and again, it's the leaders, folks who have platforms to demystify many of these rumors. And I think once the leaders become more proactive to sensitize communities, we'll see less of the teenage pregnancies coming up, but also many issues. The other thing is the family. The family should be the center of behavior transformation. In the family, speak to these young people. Someone mentioned that if you don't speak to this young girl or boy in your home, someone else is ready to speak to that person.
Yes.
So speak to your the young people. And lastly, it's about the men. The men should get involved into issues of MNCH. Walk to any of these immunization clinics and count how many men have actually brought children for immunization.
Oh, yeah.
The men, in terms of birth preparedness, the men should support. Lack of partner support comes out strongly in all our death review reports as a major factor. Women get into labor when they don't even have transport after 9 years of a pregnancy. So some men have become, should I term them as artificial inseminators? So it's a call for action for men to move beyond impregnating the women, but ensuring that the women are supported to safely go through pregnancy and childbirth.
Right.
Thank you.
Thank you so much. And that's all time could allow us to discuss, but it's been a beautiful discussion. Thank you so much, Dr. Mtumba Robert, for coming through. Dr. Mtumba Robert is the Principal Medical Officer, Reproductive and Child Health Department at the Ministry of Health. And I also had Dr. JP Bagala. Thank you so much for your time too. He is the Executive Director of Women's Health and Research Institute. We cannot go beyond here because of time, but let the discussions continue. The hashtag is Spotlight UG, and please let us continue to pay attention to issues of maternal and child health services. They're not only for the mother who is pregnant or the father, but also for us all, having a society that is well engaged. And I like when Dr. Mtumba says, men, don't just become artificial inseminators. Please be a part of this entire journey of a beautiful story of bringing another life on earth. That's all we had time for. Thank you for joining us, and a special thank you to the Ministry of ICT and National Guidance that powers us to have such conversations. I am Mildred Tuhai. Say good morning to you, and God bless you.
On the journey of AGOA, one of the things that first happened was to train over 2,000 girls.
So there were many problems